this was a very, very nice debate. And actually, I was looking even much forward to this, the second topic that I was also involved in. So I had a part of and there was a very nice presentation presented from Hungary about how to measure the hypo or hypercoagulability in patients with intracranial bleeding. So the main question was, so when we have a patient with intracranial bleeding, and of course we know that those patients are prone to when they have their first bleeding, there is always a debate when to put the patient on the preventive dose of heparin, because we know that there is a very high % of patients with intracranial bleedings who suffer venous thromboembolism. So it is always a debate what we are actually or should we do with those patients who suffer intracranial bleedings, and that we are, of course, aware that the incidence of venous thromboembolism is a little bit higher compared to patients who suffer acute ischemic stroke. So from this perspective, it is good to know when shall we put the patient on the preventive heparin, or so low molecular heparin or unfractioned heparin, that we try to prevent the patient from venous thromboembolism. So there are still quite, let's say, much fewer data published on this topic, especially when is it safe to put the patient on preventive dose of anticoagulation, and also which patients are actually more vulnerable according to the known literature to develop venous thromboembolism. So those are definitely the patients who are much older, the patients who are clinically much more impaired, so the patients who have hemiplegia. Those patients are much more prone to develop venous thromboembolism. So the debate was very, very active. In the majority, the clinicians who were also actively debating about if we can measure the hypo or hypercoagulability status, said that they don't have any, let's say, additional useful tests to measure the hypo or hypercoagulability status. But according to the data, we know that the hematoma expansion, which is very problematic in patients with intracranial bleedings, it develops in the first 24 hours, and according to that, of course, it's not safe to put the patient on preventive anticoagulation in the very, very early stage of intracranial bleedings. But then the probability of patients who have intracranial bleedings and that they will suffer venous thromboembolism is between day 2 and day 7. So according to the systematic reviews and then the known literature from the PubMed and also from other databases, is that it is safe to put the patient on the preventive anticoagulation after 24 hours. So 24 hours to 48 hours, it could be safe, but it is important to put the patient on this preventive anticoagulation. Because we know that the mortality rate of patients who suffer venous thromboembolism is quite high. So it is important to have in mind that preventive anticoagulation is very important, but of course it would be very useful to have appropriate let's say, laboratory tests to examine or to know the hypo or hypercoagulability status. But as I said, the majority of the clinicians who were actually sitting on this congress, they said that they are just like much more relying on the status of the patient with intracranial bleeding, so how much the patient is impaired according to the clinical score, and then also age is very important. But it was very, very nice to hear also those additional tests that they are using at some departments.